Broadcasting from Detroit's Cass Corridor, it's the Metro on WDET. I'm Tia Graham. Coming up this hour, should we be using words like trauma and toxic to explain everyday events? A psychologist breaks down how therapy language is misused in popular culture. And later, what psychological research says about how and why people cheat in relationships. But first, physical health has, for a while, been a major focus when it comes to taking care of ourselves. An apple a day keeps the doctor away, as the saying goes. It's generally accepted that everyone should visit a doctor at least once a year. The same can't be said about our mental health, but in many ways that's beginning to change. For one, this very month, Mental Health Awareness Month, is an opportunity for everyone to pay more attention. This increased awareness has changed the way we think and talk about mental health, so much so that it literally is altering the way we communicate with one another. Terms like trauma, gaslighting, and narcissist roll right off our tongue in ways it did not in the past. Could this help remove stigma around mental health, or does it dilute the term's original meaning? Professor Kristen Abraham is the chair of the psychology department at the University of Detroit Mercy. She joins me now to better understand the adoption of mental health language and how it's changing our understanding of mental health in general. Professor Abraham, welcome to the Metro.
Good to be with you, Tia.
Of course. So we want to hear from you as well on the phones as you're listening. Do you or someone you know misuse terms like trauma or ADHD? Has the word toxic been in your orbit more than before? Give us a call and let us know. The number is 313-577-1019. Now, Professor Abraham, I want to start with your professional experience. You train clinicians at the University of Detroit Mercy. When did you first start noticing psychological language making its way into everyday conversation?
I think I noticed this in the classroom, even with my undergraduate students, probably about 10 years ago. And I noticed that they would be using terms, and I even notice it with my PhD and my master's students sometimes. They'll use a term like triggered, or they'll use a term like toxic. And I often will write on their papers, this is a colloquial term. What do you mean? And so I've seen this integrate, and I find myself wondering, what exactly do they mean by this?
Yeah. What's the difference between someone who is becoming more emotionally literate and someone who is simply adopting the vocabulary of therapy without really understanding what's happening?
Yeah, that's a great question. I think that what often happens is there are terms that will become very popular on social media. And so they become really trendy. And when I see those terms, I find myself wondering, what does this person actually mean by that? So, for example, in therapy, there's not necessarily a particular definition to the word toxic. Mm-hmm. That's something that is cultural, and that therapists may use that in a cultural way to communicate with their patients. But it's not it doesn't have a real technical meaning. And that's part of the challenge, is trying to understand when a person is using a term because it's commonly used, or whether they mean something specific. When people are using terms that are more clinically related, that also, I think, is an opportunity, for me as a professor or for clinicians in the therapy room to ask the patient, what exactly do you mean by that, to understand?
Because I was going to say it's probably a more subjective way that, for example, toxic is being used. It's not necessarily something that you can kind of pinpoint what they're actually saying.
That's right.
Wow.
That's right.
Now, mental health data suggests younger generations are experiencing higher rates of anxiety and depression than previous ones. In your view, in your opinion, are young people generally struggling more, or are we just better at identifying it and talking about it?
That's a great question. And I don't know that the science has really answered that specifically. I think that it's a couple different things. Young people today are contending with a lot of different things that prior generations have not. In particular, social media. There was a recent study done about 2 months ago. It was published in Journal of the American Medical Association, one of their journals, not their flagship journal, but one of their journals. And it really pulled together data from over 150 different studies on social media use and later mental health outcomes, and the findings were not positive. So the research on social media and mental health in young people has been mixed, mostly because the methods that they're using to look at that haven't always been the strongest. But this study pulled together data from stronger studies, again, over 150 studies, and really found negative associations between social media use and mental health. And so I think when we talk about young people and anxiety and depression today, there's never any single cause to anything. There's never a single cause to mental health diagnoses, but that's really something that young people today are contending with that prior generations did not.
Yes. I had a conversation with someone who is from older generation, and that was one of the questions that they had. One of the main questions they had was, is it social media that's driving some of the quote unquote therapy speech that we're seeing right now? And you're saying, based on the data and the research, yeah.
Yes, and I think that the popularity of terms and the way that terms become popular, you can trace that through different social media platforms.
Wow.
So I think that's the piece that is really very different today. And really helps contribute to people's willingness to adopt a label. If they see an influencer use a term, or if they see someone who is even if they're not a full influencer, just someone who shows up in a TikTok video using a term, people are looking, generally speaking, humans are meaning-making beings.
Yeah.
They're trying to understand their own experience. And so if they see a term that they think applies, they might apply that to themselves without ever really interrogating whether the term has a technical meaning or what even maybe that media influencer or a person actually means by it.
And, just off the top of your head, what are some of the differences that you're seeing across social media? For example, is TikTok showing more of a uptick with the use of the terms versus Facebook or X?
So I can't say I have an answer to that for you. And in the scientific literature, they've only started actually to do studies looking at that.
Okay.
So there's not a lot of good data yet in particular. But I think that the work that has been done does suggest that sort of a buyer beware or a consumer beware. And I think it's important that when people are seeking mental health information, that not be the primary source that they're looking to. I know that even myself, if I'm scrolling, and I'm of a generation where I don't have TikTok, but if I'm scrolling on Facebook and I see a little video, it's compelling. And I have scientific training, I have clinical training, and I find myself drawn in to this one person saying, let me tell you the one thing that makes a difference in parenting, for example. And I think I know better than this, but it draws people in. And so I think if I had a message to younger people in particular, but to folks, is to ask yourself, how do I know this information is even accurate?
Exactly. I mean, Professor Abraham, same way. I know that, I'm a journalist and I know how to discern different information, but yet here's something that just seems so factual and so compelling. Like you said, it's hard to really know what we're listening to right now, what we're actually understanding it and digesting right now. You're listening to The Metro on 101.9 WDET-FM. I'm Tia Graham. My guest is Dr. Kristen Abraham. She is a professor and chair of psychology at the University of Detroit Mercy. We are discussing how people misuse terms that are typically reserved for therapists. And we want to open those phone lines up, and we want to ask you, do you or someone you know misuse terms like trauma or ADHD? Has the word toxic been in your orbit more than usual? Give us a call. The number is 313-577-1019. Now, Dr. Abraham, do you think the rise of therapy language in popular culture is a response to a real mental health crisis happening?
I think that it's really a response to people having greater awareness about mental health. And in that way, I think it's probably a good thing. Mm-hmm. I think that it's good that people are in tune with their mental health in a way that maybe in the past we haven't been. Mm-hmm. I also think that it's probably an effort for people to attempt to understand their own experiences. And that's also not necessarily a bad thing. So I think that whether it's technically a mental health crisis or not, I think, again, that's another term we have to be careful about using. What do we mean by crisis?
Exactly.
It is the case factually that we have seen increases in rates of anxiety and depression, particularly coming out of the pandemic. That is true. But again, whether this is a crisis, I think that I'm always a little more cautious than applying labels. But it could be a good thing that people have some level of awareness of mental health in a way that hasn't been the case previously.
Yes, and I love that you brought it up earlier, but humans are people of meaning. We're looking for, a species of meaning. We're always looking for meaning, and how can we express that? In your experience, has adopting this language raised awareness and reduced stigma around mental health?
I think in a lot of ways it probably has. I don't have any data to back up that statement, but I think in my experience, people seem to have a willingness to talk about their mental health, to acknowledge that they have, that something is going on with their emotions, and that something that they need to attend to. Much like your analogy in your opening about needing to go to the doctor for a checkup, I think people are kind of now more aware. And I think that can really potentially increase people's willingness to seek help, which is really important.
Now, we've been talking a lot about, quote unquote, the younger generation. Mm-hmm. So we're speaking of millennials, Gen Z, and now even Gen Alpha that are coming into their own, which is amazing to even think about. But I think about Gen X and baby boomers and even the greatest generation, which are, still around. Do you believe, in your opinion, that it was a lack of understanding how to ask questions about what's going on around them that limited the progress of mental health awareness?
Oh, that's a good question, too. I think that in generations, kind of thinking about the boomers perhaps, our organized systems of mental health were really only becoming to be developed when those folks were coming up as adults. And so I think it's really a function of what was even around in terms of mental health resources, in terms of, professionally, the way that diagnostic tools have rolled out. The most formalized diagnostic systems began in the 1950s, but weren't really well established until the 1980s even. And so I think that, and even then, broader population-based studies of different types of mental health conditions, how many people have depression, how many people have alcohol use disorder, for example, didn't even start beginning until the 80s. And so there really, it's not, I see this much more as a broader cultural background to this, that it's not that I think people were personally just unaware. The society was not attending to that in a way, in the way that we do now. Yeah. And so that's what I see as perhaps the largest shift.
Yeah. Wow. So what's the downside when people start using clinical language loosely in their daily lives?
Yeah, I think that one of the downsides is that it becomes a shorthand in a way that is intended to kind of communicate a certain meaning, but it prevents people from having additional conversation. If I say to somebody, oh, you're a narcissist and I'm not going to deal with you, I haven't really solved any problems. I've sort of just kind of put a label on something. And in some ways, I think the potential is for people to back away from more in-depth discussions by simply labeling something, as opposed to actually opening the door for a more critical discussion. And so I think it has potentially the effect of avoiding real problems simply by labeling them. I don't know if that makes sense.
100%. I'm like smiling and nodding because I'm just like, I think I am a perpetrator of that particular thing you're saying right now. So I was like, oh, wow. So just kind of expanding on that a little bit. When you put that label on someone, whether it is you're a narcissist or whether it is, the one that I always hear, psycho, I hear that all the time, and that one just drives me crazy. When we do that, can you explain how that does pull us away from going in depth with that particular person or that topic or that theme that would help us explore that?
Yeah. So I think what happens when we do that is we're not, if we have a complaint about another person, let's say, we're not then giving a specific complaint about what it is they're doing that bothers us. We're not providing specific feedback to someone to say, when you do that, this is how I feel. We're simply, and so that conversation gets shut down when we label somebody. We're not giving them feedback about what it is they're doing that we find annoying, hurtful, irritating, or it makes us angry. We're not giving them the opportunity to even correct that behavior. And so I think that is a limit. But I think it also shortchanges us in that we're not actually maybe even asking ourselves, what is it about so-and-so that makes me feel angry? Or what is it about what this person did that makes me feel sad? And I think a little bit more curiosity about our own experience is probably beneficial to us rather than relying on a shorthand label.
Professor Abraham, that's something that we all have to really get through. I think a lot of us, especially as you talk about the younger generations, as we talk about the younger generations of individuals who are very quick to label someone and kind of throw them to the side, cast them off as if, as if they're trash. And I just, we have to explore that as a society. But you work with clients every single day. Have you seen cases where someone's adoption of psychological labels have actually gotten in the way of their progress or their ability to cope?
So, as a point of correction, so I'm not working with patients every day. To be clear, I do supervise some work that our students do.
Nice.
And some clinicians in the community. But I have seen people at times over the years where they are attached to a particular diagnosis. So maybe someone is convinced, for whatever reason, that they have a diagnosis of obsessive compulsive disorder, or they're convinced that they have a diagnosis of ADHD. And if they do have that particular diagnosis, that can be really informative to talk with them about what the implications of that are and what appropriate treatment is. But if they don't, it becomes really kind of a question I have as a clinician as to what is it about this diagnosis that is so important to you? And the preoccupation with it sometimes can get in the way of them actually moving on and pursuing things in their life that they care about, whether that be other relationships or whether it be an education or a job. This kind of label has become a barrier to them actually engaging in their life. And that's what I see as a real danger. And that, to be fair, that can happen whether or not the person actually has the whatever given diagnosis it is. But it's the attachment to the diagnosis that can sometimes prevent people from moving forward.
Yes. And when a term like triggered or trauma gets used so broadly, because we're talking about just how language is being used loosely in our daily lives, when they're used loosely or used broadly, how does it impact the people who are generally living with those experiences?
So I think I'm going to take these separately. I think triggered, is an interesting word. This also shows up in students' papers. And I ask, what do you mean by triggered? I think what people mean in commonplace is it's something that we used to say years ago pushes their buttons.
Yes.
Right? Something upsets me. Either it makes me angry or it irritates me. And I think that's what people mean by triggered in a colloquial way. But again, I think that's the opportunity for a little bit more curiosity about what is it about this that upsets me, and what is it about this that makes me angry, and trying to understand that. And I think trauma is a little bit of a different ballgame. And so that term, I would say, we do have a technical clinical definition of that. And when I talk to students, I tell them trauma with a capital T in a diagnosis sense usually means something where someone has been threatened with serious bodily harm or injury or death. They've witnessed someone experiencing that. And we're talking about very serious things like sexual assault, natural disasters, physical assault. And that's kind of what the term trauma with a capital T means. But there are a lot of other experiences in life that are traumatic for people. I'm thinking about experiences, particularly people who are minoritized racially or gender and sexual minorities, where they have a variety of experiences that might not meet that capital T trauma, but that are deeply, deeply harmful to them. And I don't see a problem using the word trauma to explain that. I think that it honors that experience. And so I think that term is is important. Now, if someone experiences trauma because they go to their favorite restaurant and they're out of their favorite dish, I think, or you can't get the product you wanted to buy online, you can't get a Nido or something. I think that's when the term becomes misused and maybe isn't really honoring the serious experiences people have had.
You're listening to The Metro on 1019 WDET. I'm Tia Graham. My guest is Professor Kristen Abraham. She is a professor and chair of psychology at the University of Detroit Mercy. We're going to take a break, but when we come back, we will continue our conversation with Professor Abraham. Phone lines are open, and we're asking you next if you've benefited from a self-help book at all, and if so, how did it impact you? You all stay right there. We'll be right back. This is The Metro. This is The Metro on 1019 WDET FM. I'm Tia Graham. So-called therapy speak has shaped the way people communicate to one another. Gaslighting and toxic were once jargon terms reserved for therapy. Nowadays, people use it to describe everyday scenarios. I am one of them. I'm joined by Professor Kristen Abraham. She is the chair of the psychology department at the University of Detroit Mercy. We are discussing how adapting this language can complicate our understanding of mental health. And we want to hear from you. We want to hear your thoughts. Do you or someone you know misuse these terms like trauma or ADHD? Has the word toxic been in your orbit more than before? Give us a call and let us know. The number is 313-577-1019. And then as well, have you ever used or benefited from a self-help book? That phone line is open, 313-577-1019. Now, let's jump right into those phones right now. We have Cindy from Ferndale. Cindy, what's on your mind?
Hi, I'd like to add a couple terms to this list.
Okay.
Number one being Tourette's.
Okay.
I have one of my best friends who was diagnosed when she was 9, and it's a pretty serious affliction, and she has a pretty serious case. And then anytime somebody says something stupid, they blame it on Tourette's. And that just gets my goat.
Now, Cindy, when you do hear that, what's your initial response? Do you speak up? Do you speak out?
It depends on if I know them or not. I'm not going to do it to the guy at Starbucks. I might, but depending on my mood.
Oh, Cindy. But you said you had another word as well?
Oh, disaster/nightmare. No, gum in your hair is a nightmare. A tsunami is a nightmare. The example you use, not getting a table at your favorite restaurant, honey, it's not a nightmare.
Cindy, thank you so much for calling in today. And Professor Abraham, how does blaming behaviors on actual mental conditions impact our ability to understand them more?
Yeah, this is a really important topic because I think that, what Cindy's pointing out is that people's use of the word, for example, Tourette's, to explain misspeaking, is really devaluing the seriousness of a neurological condition that's really impairing for people. And so it doesn't honor the struggles of people who have that condition when we're using everyday experiences or we're labeling everyday experiences with what really are clinical terms. And I think that can be really difficult for the people who experience those conditions in reality.
Yeah, because it's as if they're being made as a joke the whole time. That's just... Cindy, thank you so much for giving us a call out of Ferndale. Now, Professor Abraham, I want to turn to self-diagnosis. It has become increasingly common, especially among young people on social media. I keep bringing myself into this, but I'm a perpetrator of it. Do clients arrive in the office already convinced they have a particular diagnosis, or have you had that experience in the past?
Yes, I think this is something that happens quite a bit, where people will come in and they have an idea of what their diagnosis is, and sometimes they might be correct. I think it's not, we all as humans experience anxiety. For someone to come in and say, well, I might have an anxiety disorder, statistically speaking, anxiety disorders are our most common mental health diagnosis. Over 20% of people are going to have that diagnosis, so they could be right. Yeah. So I think professionals have to be open to that possibility. But what's important for people to understand is when someone comes to a mental health professional to make a diagnosis, the professional is doing, firstly, a clinical interview. They're asking the person a lot of different questions, not only about right now what their experiences are, but what they've been in the past. And then sometimes they're doing even more in-depth assessment or psychological testing, and they're trying to understand, do these persons' experiences match up with what other people with known anxiety disorders experience? And so there's a lot more level of depth that goes into a mental health professional's diagnosis versus the self-diagnosis. So I don't know that there's anything inherently wrong with self-diagnosis to start. Again, I think people are trying to make meaning of what they're experiencing, and they're looking for a way to do that. Mm-hmm. And I think that's a good thing. I think the challenge with self-diagnosis is when they're relying on sources of information that are inaccurate or incomplete or misleading, and that can get in the way of people actually being open to what might be an accurate diagnosis. The other thing I'd like to add on this point is that when a mental health professional makes a diagnosis, they're not doing so just for the sake of making a diagnosis. They're doing so because it provides them some information about what they can expect about this person's experience and what kinds of treatments they know will be effective. And so when people are self-diagnosing, I think they have to ask themselves, what am I actually looking out for here? What am I trying to get out of this more than just a label? And I think that's a really important question about self-diagnosis.
In a medical setting, clients are encouraged to advocate for themselves. How would it play out if a potential client arrives and assists? They know what is going on with their mental health and they don't want to take medical advice.
I think it becomes the question, it would be, in what way as a therapist could I be helpful to you? Mm-hmm. If you've come in with this decision already, what kind of services are you looking for from me? And I think that would be the kind of question a therapist might ask, is if you've made this decision already, but yet you're here. And so what can I do to be helpful?
Yeah.
And I think that might shift the tone a little bit. If a person is that kind of wedded to an existing diagnosis, it helps the mental health professional get beyond that a little bit to try to understand what the source of the person's distress is and how they can be helpful.
And Dr. Abraham, self-help books, we're going to move along here, but self-help books have been, a consistently popular genre of reading in the U.S. Books like Atomic Habits by James Clear or Thinking Fast and Slow by Daniel Kahneman. How different is that from therapy speak? We talked about it a little bit. Is one feeding the other?
I think they may be feeding each other to some extent. Mm-hmm. I would say I think self-help books can be very useful to people. I think they're more accessible they're certainly less expensive than mental health care, and I think that can be useful. I think the challenge for the consumer is to know whether this is something that's reputable. And so I have a few things that I think are important for people to kind of consider when they think about this. One is the person writing this book, what are their credentials? Are they a licensed mental health professional? Are they someone whose background might be in business, which could be very useful if you're interested in a business self-help book, but if you're interested in a mental health self-help book, perhaps less so. Yeah. But when I say mental health professional, I'm talking about people who are either psychologists or psychiatrists, social workers, counselors, potentially advanced practice nurses who have specialized psychiatric training. But I'm thinking about this is what I mean by a mental health professional. So I think one piece is knowing that. The other piece is there are a variety of self-help books that are backed by scientific research. And so the way that a person can identify those is usually in the beginning of the book. The person writing the book has kind of a whole discussion about this is where the information came from. And in the back of the book, it feels a lot like school to people, and I recognize that, but there's a really thick list of references. And they're pointing out this is based on actual scientific studies of hundreds of people. In contrast, there's a lot of self-help books that might be based on one person's experience, their own ideas or their own opinions, or sometimes for mental health professionals, they're based only on their own experiences with patients, which could be very valuable, but that's still a very select group of people that this mental health professional has seen. And it may not be generalizable or applicable to a broader audience. So I think this is another one of those kind of buyer beware issues, the same way on social media, is helping people to really think about evaluating the credibility of the source before jumping in with 2 feet.
Yeah. You're listening to The Metro on 1019 WDET FM. I'm Tia Graham. My guest is Dr. Kristen Abraham. She is the professor and chair of psychology at the University of Detroit Mercy. We are discussing how people misuse terms that are typically reserved for therapists. Now, I want to get into debunking some of these popular terms that we've been discussing and using freely throughout the hour so far. Our first example is a narcissist. This is commonly used to refer to anyone who seems self-centered, vain, or posts too many selfies. What are we getting wrong with this one?
So when we talk about, I think this comes from the term, there's a term narcissistic personality disorder.
Yes.
And that is really a clinical condition that mental health professionals can diagnose when someone is unusually grandiose. They come across as thinking about themselves as being better than other people. They expect other people to recognize their specialness. And when other people don't recognize that, they tend to react with anger. And they really don't have a lot of empathy for other people. They have a hard time understanding each other's experiences. Now, it's important to note that it may very well be, and many mental health professionals have come to the understanding that what's behind this kind of narcissistic veneer, this grandiose veneer, is really actually a sense of a very fragile sense of self-esteem. And so it can be helpful. Mental health professionals often understand that hostile or angry behavior is a way of protecting the person's own kind of sense of vulnerability. But I want to be clear that someone who's simply posting a lot of selfies or might be really self-centered and selfish, that doesn't necessarily rise to the level of a narcissistic personality disorder. When mental health professionals make that diagnosis, they're not looking at a single sample of someone's behavior. They're looking at people's experiences over time, how their relationships have been, both their personal relationships, their professional relationships. They're trying to get a much deeper understanding of someone before they're going to apply a label like that. And research studies suggest that really kind of at maximum, this might be about 6% of the population. So it's not wildly common. And certainly the term is thrown around much more than would suggest what the diagnosis is about 6% of the population.
I mean, Dr. Abraham, if you could see my algorithm right now. I mean, it's pretty rough right now.
100% of the population.
It's just 100%. That's what it tells me right now. But another term that I hear quite often, honestly, gaslighting, is typically used during any disagreement, contradiction, or when being told you're wrong. It's often deployed when someone simply disputes your account of events. What are we getting wrong with gaslighting?
So this is a really interesting term, and I have to tell you, I had to do a lot of research myself on this because it's not something that I use. In no psychology textbook does this term appear. So the term really originated in a 1930s play that I think was called Gaslight, and then was later made into a movie in the 1940s. And my understanding, I've not seen this film, is that the depiction is an abusive husband who is lying to his wife, but leading her to question her own reality and her own experience of events. And that's really what I understand to be the origins of this term. It seems that the term became more popular in the early 2000s when a psychoanalyst published a popular press book explaining her own experience of being gaslit and that of her patients. But there's very little research on this term. And so this is something that's coming forth.
Professor Kristen Abraham is the chair of psychology at the University of Detroit Mercy. We were discussing how people misuse terms that are typically reserved for therapists. We're going to have you back to continue this conversation. Professor Abraham, thank you so much for being here with us today.
Thanks for having me.
Coming up, what psychology research says about who cheats in relationships and why. You all stay right there. We'll be right back. This is The Metro.